will be pertaining to issues in regards to the healthcare industry and inequalities that have faced the healthcare industry. And additionally, we will be talking about preventative measures that we can take to possibly stop these inequalities. So the first question would be, how would you describe health disparities? Either panelist can go, whichever feels more comfortable to answer the question first.
Sure. So I think I come from as probably a slightly different angle because I'm not trained in public health. So a lot of the disparities that I see within healthcare are related to both patient access to healthcare and patient outcomes and treatments, so kind of all aspects of a patient's health that are determined by kind of barriers that they face that are established within a system of healthcare that they're trying to operate within. And I think that's kind of the broadest that I can make it right now from a clinical standpoint.
I would kind of add that we see a difference in access to health and health outcomes, as you said, and disparities occur across many dimensions, including race, socioeconomic status, location, gender, disability status, and sexual orientation. So we see that across the board, and the impact on that has a wide spectrum. It spans out to a lot of things. And we know there's many factors that contribute to why some people get better health and access to health care, have better health outcomes, live better lives than some other people.
Those are both amazing points. The next question is, how does education affect health disparities?
Oh, okay. You want to go first, Elizabeth, or you want to take turns?
You can go ahead. That's totally fine.
I think education plays a big role in a lot of different ways, but we can't always put the onus on education. So I think as a society, we all need to be better educated about how to take care of our bodies, how to eat better, how to do things better. At the same time, we're being bombarded with lots of different messages that are unhealthy. We need to provide, how you have access is, do you know that what's available to you? We have to have education in the school system and K through 12, but also all of you are students in a college environment, and education around disparities and differences that people face should be part of your curriculum, not an elective part of your curriculum, but a core part of your curriculum. And we see sometimes that doesn't always happen because the science rules. We think that the science takes care of everything. The science will eliminate racism. The science will eliminate homophobia, transphobia. We think the science will do all of that. And we have to remember that as people are scientists working with people who are bodies, these bodies are connected to families, cultures, communities, and those communities have a social, political, and cultural history that we have to remember. How does that trickle down and impact, one, why they go seek services, why they don't trust the system, why there's fear around it. I like to say in my classes, when I'm a patient, I go into the hospital where Elizabeth is the doctor, and I may have a PhD, but once I'm a patient in that hospital with this doctor, I don't know the knowledge. I have to trust her. The language is different. I'm lost as a patient, even though I'm an informed, educated person. But me, the patient, has fear. Me, the patient, goes into an environment that's absolutely nothing that I know.
Yeah, I completely agree with all of that. I think even as a physician, when I'm a patient, the roles are completely reversed and you lose that power dynamic of being able to walk into the room and say, I'm Dr. So-and-so. So it's really powerful when you have that reversal in your role within that encounter. I think, as mentioned, the education piece comes from every single level, right? So it's, from my standpoint, helping patients to directly provide them with education to help with their health, point them to reliable resources if they want more information. But from kind of my own standpoint, I think it's also really important for everyone in healthcare to take on their own education initiative and really understand the history of a lot of these disparities, as you were mentioning, Dawna. And I think when you start to understand that background, it gives you a little bit more information in terms of how maybe you should approach future interactions with patients, or ways that you can try to help address the barriers in a more proactive rather than reactive manner.
Thank you. So the next question is, what disparities do you all witness in your research or jobs?
Oh, okay. Many. Not only do I see disparities as part of my research, but as a person who goes to the doctor, as a person who's taking care of an elder, I experience the disparities personally, or the difference and approach to me. But I started my career as when I was a graduate student, and I was, you know, when you're a graduate student, you become a work study student, you work on a research project. And I was working on a project in the Center for Social Policy at University of Massachusetts. And we were looking at alternative housing for people with disabilities as part of a phase of deinstitutionalization, getting people out of institutions. And they opened up elderly housing. And so I was just, you know, entering data, very simple. And I said to the lead researcher, there are no people of color in any of these programs. And so her response to me was, they take care of their own. And so that has been an underlining theme about my research, is because sure, they take care of their own, but the next question is, why should they take care of their own? Why are they taking care of their own? So part of the issue is who's at the table developing the programs, asking the questions, bringing up the issues for people that they don't see. We need more voices at that table. So you see the disparities start in the beginning when we're developing programs, research studies, outreach to communities. We see it start there, and then it trickles down. It trickles down from the communities not knowing what's available. In my first study, when I was looking at disability in the Cape Verdean community, and I interviewed 65 people, a group that were families with children with developmental disabilities and a group of service providers. The families did not know that they had services available to them. The service providers who live in Massachusetts did not even know about the Cabo Verdean community, although they've been here since the middle 1800s. They didn't know who they were. And so we see that disparity. That's how we don't know what's available to us.
Yeah, I think from a kind of clinical practice standpoint, everything from the measurements that we use for patients is developed, you know, primarily on a white population. And when you look at things like pulmonary function tests, there's a different standard for different races, which should not be the case at all. There's no biologic reason for that. And similarly, nobody's gone back to ask, well, you know, why do different races maybe have worse pulmonary function, and what's the story behind that? And nobody's really delved into it. And then on a day-to-day standpoint, I started getting interested in differences in care kind of throughout the end of my medical school and the beginning of my residency. When, you know, at BMC, we interact with a lot of patients who come from different backgrounds and speak different languages. And there does seem to be a difference in not only the way that they interact with the medical system, but the basic needs that these patients have compared to others. And I felt like they were kind of falling through the cracks a little bit more in terms of the resources that they were accessing. And then that led to kind of poorer outcomes. So I've been really kind of quantifying those poorer outcomes in an effort to try to produce kind of a measurable thing to say, you know, this is exactly the disparities that we're seeing and the impact that they have on our patients. But it's everything from, you know, basic necessities to access to, you know, interpreter services and in things that really matter. So, you know, stroke outcomes and access to emergency services and education around stroke all are kind of across the board have like poorer metrics and poorer outcomes in patients that aren't white, you know, in the same country, in the same health system. So it's, you know, every step of the way and kind of any facet of somebody that's different from just the typical like white person, I think can impact your healthcare, which is a kind of a scary thing to think about, but I think the reality of the system we're working in.
Okay, so the next question is, what do you believe your role is in lessening health disparities on a day-to-day level?
You take that one first.
Yeah. I mean, I think it's really hard because it's such a big topic. So I try to kind of break it down into different levels. So when I'm thinking about the interactions that I have with patients on a day-to-day basis, I really try to be aware of, you know, my own beliefs or biases towards patients that I'm seeing, trying to acknowledge what history these patients or experiences these patients may have had with the health system, and then trying to create an environment that is welcoming and kind of understanding and respectable of that relationship. And then I think on a larger scale, within medicine, I've tried to educate other providers around me on these topics and tried to get resources within the clinic to try to help address some of the patients that maybe had less access to community resources or weren't tapping into community resources as much as other patients. And then on more of a systems level, we're working and have been working for quite some time, but need to do a better job of getting more diverse medical providers and getting people from different backgrounds, because obviously that's going to help to start to help patients feel more comfortable within the medical system so that we can provide better care for them. And then everything up to kind of like state policy, advocating for, you know, better housing for kids who have complex medical needs and, you know, patients who have different abled bodies than others, and trying to get them the accommodations that they need. So it's, you know, on a day-to-day, I think it's the stuff that I do in clinic interacting with patients, but there's kind of the background of all of those projects and layers that go on as well.
That's great. I think for me, teaching all of you at Simmons, my course is Race, Gender, and Health, Illness and Society, Disability and Society. One of my assignments, and some of you have been in my classes will know, is that you have to write a paper about a group. It has to be culturally competent with cultural humility. You have to understand what self-assessment is, how you see yourself in the process. That project that when I was a graduate student has stayed with me, that now I'm the person, if I'm at a table, I bring up the issues. If I'm on a dissertation project and someone is doing a study and it's around, I'm sorry, there's noise outside. Someone's doing a study that's related to health and disability. One of the questions I actually say to them is, you need to put a question, how do you work with patients and clients who are different than yourself? We can't assume, even if we are a part of a community that has been marginalized and is vulnerable, that we don't have to do cultural competency work. We all have to do that kind of work. So I like to help others. I think about that. You are all the future. You're the future providers. It's my responsibility to help you think about these questions and about these ideas. So I try to craft my assignments around that. Also, my community work, I live in Roxbury, and I've been doing community work for a long time. And being part of that, being part of how people see our community, how we do things in our community. This summer, I was fighting gentrification in my community and on my street with developers, and we had a very small victory, but it's being, it's having boots on the ground. It's sometimes saying things that other people don't like you saying. One of the warnings that I give students when you embrace this work, it is hard work. Not everybody wants to hear about it. Not everybody wants to address it because it's hard. It's hard to think about it, but also we have to be patient with ourselves. One of the things, medicine is part science, it's part art, and it's part mystery. There's a lot of trial and error in all of our research, and we have to figure things out. We learn from our mistakes. Although some of our mistakes involve other people in the community, we have to try to figure this out. I think COVID is a perfect example of the trial and error of everything that's gone on this year. So I think one of the things in the article that I have students read is that it's a lifelong journey, that I'm gladly to be in it. Sometimes I'm frustrated by it. Sometimes I'm saddened by it, but most often I'm joyed by it because I get to help all of you, the future provider. You're going to be my future doctor and nurse one day. And I want you to see who I am and be able to treat me and understand all the little facets of me and other people like me.
Yes. So the next question is, where do you see the future of healthcare going?
Oh,
It's a hard one.
it's a hard one.
I think, well, I think, as Dawna was saying, it's going to require patience, right? I think it's going to be a very slow process to make any changes. I think very slowly, people within healthcare are becoming more aware of these issues and having more conversations about them, which is nice to see. And I think especially within the specialties, so it used to be that general practitioners were the ones who thought a lot more about these issues. And now, hematologists, cardiologists, neurologists, every, department is starting to have studies realizing, oh, this is happening within my field as well, and I can't just leave it up to the general practitioners to try to solve this. And I think there have also been some really nice studies coming out of focus groups that different hospitals have been doing with their own patients and having more conversations about the reality of what it is to be a patient within their hospital system and trying to figure out, what is your relationship with the physicians here? Do you like your physician? Do you not trust them? Why don't you trust them? And how can we make this work better for you? And I think having those conversations is a nice place to start. And then I'm not going to pretend to have the answers as to, all the changes that need to be made. But I think based off of kind of those conversations and what we're learning, then hopefully we can take some baby steps to making the larger system more, applicable to everybody.
I think we have to remember that part of this has to do with policy development and how we vote. We can't forget how we vote. And part of the disparities is what kind of health insurance do we get? Even if you have the best health insurance, we are consumers in a healthcare system, but we're unequal consumers because it's not a product we can return and get our money back. But, you know, there's boundaries that we have, even with the best health insurance. Sometimes you can't get what you need because there's other agencies or groups that will control. Can you get an MRI? Can you get an MRI only if you're going to have surgery? So we have a lot of things that are contributing to health disparities, not just where you live, but how are these outside, how insurance affects this. And part of that is from policy. And one of the ways that we as consumers of the system, because we are all consumers of this system, is that we constantly write our our politicians, our voice. Even though you think that you don't have a voice, that letter gets counted in somebody's office. And our vote gets counted. We see this last year after we came out of the Trump administration. Our vote does really count, and our voice does count in that way. So we can't ignore the policy part, because if we don't do that as well as be boots on the ground, then we're going to keep being like the hamster in the wheel. And some of that, you know, and it's not going to be easy. I think, like Dr. Wilson says, is that we need patience. It's going to be slow. There has been some progress. There's a lot of things that we're going to learn from COVID, the rollout of COVID, the gaps that were in COVID, the missteps that are in COVID. All of that is a learning process. And I know researchers are on top of it now. We all should be on top of it to see what we can learn from it and do better. I think one of the things that came out of COVID was it highlighted the disparities that were already there. And I kept hearing on the news is that they were talking about the Tuskegee study. They're talking about Dr. Simmons. They're talking about women being sterilized. All these things came to public knowledge, to the general public, even though it was known in different places. I like to say when they talk about Tuskegee, they talk about the men and they forget about the women. What happened to all the women that the men were involved with in that Tuskegee study? So we have to do a lot of things, and all of you are part of doing that things. And I say, write your congressperson, get your voice out there. That is not a little thing.
No, and as somebody who's in healthcare, the really, the voice that you have is very impactful when it comes to policy in Congress, and individual patient stories are also very impactful when you're thinking about trying to like propose a bill or change legislation. So, using those cases that you're like, oh, this should have, never happened, or I can't believe that this patient had to go through this process, or whatever it is that you find really upsetting that you would like to change, including that story when you're writing these letters and having these conversations actually goes a really long way. So definitely do that.
Yes, you guys actually went right into the next question. So the next question is, sorry, if you want, you can direct your attention to the chat as well, Thank you, Mr. Gurney, for your insight. So what do you think Boston officials could be doing to lessen the negative impacts of COVID in underprivileged communities?
I think it's hard. I think a lot of it comes down to day-to-day resources, money, space, housing, that people just don't have. And that's really hard to change. So, I mean, I think advocating for those things and raising awareness about them is helpful, and has started obviously in the conversations that have been happening in terms of where COVID outbreaks are happening. But again, I don't know how quickly those things are going to be able to change.
I think one of the things that we have to do is, where are people getting their information, and learning where are people getting their news from. And if we have to look across generations and how news is rolled out, how information is rolled out. You're a generation that texts, that does social media. And one of the lessons we learned from COVID is that there were people, marginalized people, people with disabilities, and how in their homes that couldn't get access to get to vaccination sites, didn't know where the vaccination sites, they did everything online. And then someone thought about the 211 number. to help people who didn't have computers to get online. It's not just generational or age, but how do we disseminate information? How do you gain your knowledge and your information? How does someone who's 40 to 50 years old, how does someone 65 and older, where do they get their information from? And it's not just getting the information, but having the relationships with organizations that are around or doctors that are around. One of the things that we did in the neighborhood association when we weren't getting vaccinated in Roxbury is they started blasting, and not just through email, but neighbor to neighbor, we're talking about here's where you can go. Here's somebody who's got a car that will take you. And it took, it comes back to boots on the ground. Doing some of the work. It's boots on the ground saying, here's how we do this. And we have to be able to learn from what worked during COVID and what the mistakes were, and not to forget it, because we've had this problem in other ways with other situations. And what happens is we have a moment of crisis, we roll out everything, we see see what worked, what didn't work, and when things get better, we go back to normal and we forget. We can't forget. We have to come back and say, well, how do we now proceed and how do we make it better? I think one of the things that physicians have is a lot of pressure to get patients in and out in 15, 20 minutes. A lot of pressure for that. And that gives very little time to develop a relationship, to develop that trusting bond. I think when my primary care physician retired and I had her for 20 years, I fell through the cracks. I didn't like the next person I got. They were really thinking about, you don't really need an x-ray for this. You don't really need an x-ray for that. There's pressure on physicians from insurance companies on what they can give patients for tests. Guess what? I really did need those things. We all need some of those things. I think what happens with the policy is the pendulum swings one way, and then to correct when things go awry, they swing it the other way, and there's no balance. We have to think about putting balance back in the equation, how to work, how are all these things going to work. So it's a lot of things. This is a multidimensional problem, issue, and solution.
We're already seeing the pendulum swing in the other way. In that at the beginning of COVID, any kind of conversation you had with a patient counted as a visit. So you could have a telephone visit with somebody and that would count, and you would get credit, you'd get billed, the hospital would get reimbursed for it. And now phone calls don't count anymore, and it's just telemedicine visits. And soon enough, they might not even support telemedicine visits, which is a huge issue because a lot of our patients don't come to their appointments. So one of the great things about COVID is that I've actually seen more patients and had follow-up a lot more than I typically would. And being able to do phone calls increased that even more because it took out the complexity of, having to log onto a computer and do a video call, and then, their volume doesn't work, and how do you troubleshoot that? And being able to just call your patient, have a conversation with them like a normal human and check in and see how they're doing made a huge difference when people were so isolated. So I'm really upset that phone calls were taken away as a visit. They still happen, we just don't bill for them, but I think it would be awesome if they wouldn't kind of go back to just being in-person visits, which they might not, but it is kind of a scary possibility.
It's like having the old-fashioned when the doctor came to your house, and
really nice.
But, and we can't really do that in this environment. I mean, if we were in a small community, yes, we can have house calls, but in a big city, and I do know some doctors who do that, who do make house calls, but in a big city, how can we get better at that? And I think the phone calls, they should reimburse the hospital and the physician for those phone calls, because here's where you're establishing the relationship. The doctor's going to call the patient, makes the patient think, I'm important to you. You are thinking about my well-being. I'm really important to you. And that we have to change. But that comes down to money. That comes down to policy again. That comes down to what's insurance going to cover.
Okay,
So the next question is, what can citizens in Boston or students in Boston, in the Boston community, do to be aware and inform those who don't have access to healthcare?
And I think you guys are, taking the first steps, which is great. I mean, like educating yourself, educating those around you, having conversations about these topics, and then just, being out in the community and raising awareness that way. So advocating for these changes, going to a rally to help prevent gentrification. I know Northeastern students just were rallying against the new building that they're putting up, the new dorm that they want to build, and saying that that's contributing to gentrification. And then, as we mentioned, also just keeping the conversation open with the policymakers and advocating for the patients that, or the individuals that you will see.
I think it takes multiple approaches. I mean, we have vans that come and do vision tests, mammograms, things like that, that would come out to the community. Having information that's disseminated in grocery stores, little bit neighborhood stores, churches. We have to involve the grassroots. We have to do both, the grassroots and mainstream avenues. You have to do both of those things, because people who don't go to the doctor, they don't trust the doctor, they don't want to go to the doctor. And also we have to educate physicians. If somebody hasn't been to a physician for a long, long time, and what really drives someone to the doctor or the emergency room is when they can't medicate themselves anymore. They can't develop a salve to fix that sore. They can't have a potion that fixes it, and the pain gets too much. When they show up there, and I know the physician's frustrated because this person hasn't been to a doctor in 20, 30 years. Now it's time to back up and say, okay, what should we kind of check right now? And it's expensive to do that. But this is for the benefit of the patient, because there's something that went wrong that actually made them get there. There's many reasons why people don't go to the physicians. They believe they're healthy. Why should I go? I don't feel bad. Why should I go see a physician if I don't feel bad? The idea of annual checkups, well, that's science driving me to do that for my money. You want my money. That's why you want me to go for annual checkup. So we have to be patient with that. It's understanding, who gets the information, how they translate it, take it in, not take it in, and giving them respect for their feelings. I think one of the people, what's happened in COVID is people that don't want to get the vaccine. It's very frustrating. It's very hard to deal with. I think Dr. Fauci said, but we have to respect that person and their decision and help them understand why they would benefit. And also not assume that it's poor people or people who are not educated don't want to get the vaccine. It crosses all spectrums. You just don't see people who are in low socioeconomic status don't go to the doctor. You see people who are very smart and who have lots of wealth who don't go see their physician. So we make these stereotypical assumptions about, disparities, and that there's no assumptions in this process. We have to get rid of that.
Okay, so the last question is a two-part question. I'll read the first part, and then we can address the second part when you guys are ready. So in what ways can we as students challenge health disparities? That's the first part of the question, if you guys want to address it.
Require your departments, your professors to talk about it, first and foremost. Go back to the administration of your university and say, I don't want this course as an elective, I want it as a requirement. I want to learn about other people than myself. We know the textbooks were based on a white male paradigm. We want to shift the paradigm. And that's you students saying, guess what? In my core curriculum, I'll make room for it if you give it to me.
Yeah, I agree. I think it's seeking out the educational opportunities and asking for them when they're not there. And a lot of the times it is just asking for the educational opportunities. And if the person you're talking to doesn't know, asking, well, who is somebody that's doing this work that I can talk to? I always, whenever I meet with anybody, I try to go away with having at least 2 other people that they recommend I talk to, and then you just build your network that way. And you kind of get the different perspectives about whatever topic you're trying to learn about. So that definitely applies here as well. And it doesn't have to be within the same institution, right? Like you're in Boston, which is wonderful because there are so many universities, colleges, hospitals, people that are doing this kind of work, and they're so close. And especially now when you can just have a Zoom call with somebody, knowing that there's nothing wrong with, trying to pick somebody's brain at some other institution. That's totally acceptable.
And then the second part of the question is, are there any suggestions on how we can further educate ourselves and be more aware of our surroundings, especially as future healthcare professionals?
I mean, I think a lot of it is going to be somewhat like self-directed, aside from going through something more like a master's program or higher education that's targeted towards these topics. One of the things that I did when I was looking at medical schools was asking what kind of curriculum they have around diversity, and they're not all very focused on that. So trying to, as you're seeking out other education opportunities, acknowledging who's going to be able to provide you with that education, or if you want to do work within this area as you're moving forward in your career, making sure that wherever it is that you're at, there are mentors that you can look to and that are doing this kind of work that can help guide you through it. And then eventually, you're going to start mentoring other people and doing your own kind of work and projects to try to move the needle a little bit. But I think that would probably be my biggest suggestion, is wherever you go, make sure that there's some form of curriculum and a specific mentor that somebody can point you towards that would be able to help guide you through that education process.
I agree. Also, the fact that you have this panel, we've said this before, and it's great that you're doing this already. And I think keeping an open mind and an open spirit is part of the process. And and it's going to be hard, but always challenging what some of the status quo that you'll find, and saying, and being brave enough to ask the questions and keep digging deeper. And this panel's doing that.
Thank you guys so much for answering our questions. Now I'm going to open up the floor to any additional questions that the audience might want to ask our Miss Dr. Thomas or Dr. Wilson. JD, you can go ahead.
Hi, I'm sorry if you can't hear me that well. There's like music going on in the background, but I just want to say I really appreciate and value both of your perspectives on this issue. I know, Dr. Wilson, you work a lot with like underserved populations at BMC, and I've seen this firsthand being part of the tech team as well. I know in Professor Thomas's class, we talked a lot about taking more of a preventative approach to healthcare. And I was wondering if you've seen like any specific examples that you'd be comfortable sharing in your office that kind of highlight the importance of a preventative approach.
Sure. I think the preventative approach is probably one of the hardest things to do actively in the clinic. I think a lot of the stuff that we do is more kind of reactive, unfortunately. But one of the really nice things that they've tried to do is start programs that are geared towards common needs that patients have. So one of them is the free tax service that was started by one of the residents at BMC and has now been going on for a few years. And the idea is that patients often don't file their taxes, or they don't file them appropriately, so they don't get the tax return that they deserve. So they've actually been able to get patients a significant increase in their tax return. And then that is a way to, you know, just generally support the needs of the patients. And I think, you know, they try to develop as many programs as that as possible. I think right now in practice, a lot of what we're doing is screening patients continually and hoping that by screening them every time that we see them or calling them and asking them what their needs are, we can identify the need as early as possible. And, you know, some of the screening questions aren't related to, you know, are you about to be evicted or do you not have any food? It's the concern that it might happen. So are you concerned that you might run out of food or that you might not be able to pay your utilities this month, as you know, from calling these patients? And then really trying to connect them with community resources in an effort to try to kind of prevent that need from coming to fruition. But it's very tricky in a clinical setting, aside from doing those things right now. But I think that's what we have established. It can be better for sure, but that's kind of what we're doing currently.
Interesting, thank you.
Mm-hmm.
Any other questions? You can also leave your questions in the chat if you feel more comfortable.
I have a question. I'm not sure if this already addressed, my question is like, what are the current like challenges to address disparities, like in terms of if you're like a physician, like in the medical field, how would you like, if you encountered health disparity like in front of you, how would you like what's the best way to address it and like take it to like a more serious department wise, like take it to the authority and like make sure that they're being addressed? What would be advice or step toward that?
Yeah, I think it depends on what exactly the disparity is that you're seeing. So if it's something that is specific to the patient, which I think rarely happens. I think a lot of the disparities that I see are probably more related to the system, larger issues. You know, I don't think any patient within themselves has anything that they like need to change, but I think just functioning within our system creates the disparity. So if it's within the individual encounter, just trying to work with that patient, meet them where they're at, and help them make whatever step they need to make in order to help improve their health. And sometimes it's just baby steps or providing them with information and then, you know, not making a change and just saying, okay, we're gonna, you know, we'll talk again about this later. Like, you know, I'll give you some time to think about it or talk to your family and come back and we'll answer questions about it. I think a lot of the disparities, the most common ones that I see are probably related to systems not being able to meet all of the needs of the patient. And in that setting, I think it's coming up with creative solutions and then proving, unfortunately, proving that there is a financial incentive to make that change. So I think a lot of these things come from like the work that I do, saying, you know, if we don't address these needs, these patients are going to come to the emergency department with seizure, and then you're going to have this big hospital bill. And that's not really what you care about as a physician. You want to help the patient, but that's the way that you kind of advocate for the policy change. It all comes down to kind of proving that financial incentive for the hospital. And then similarly, when COVID started, BMC rolled out this vaccine van that went out into the community and vaccinated the children. And that was wonderful because we needed to go out and like meet these families because normally we see them every few months when they're babies, and we were missing those appointments. But again, they had to kind of prove that this was going to be something that was going to benefit the hospital as a system as well. And I think when you're able to navigate those, then that's when you see these larger scale changes happen that address the disparities that you kind of see on a more day-to-day basis or that you see more patients facing.
So I'm gonna just address some of the questions in the chat. So one says, what do you think most doctors' attitudes are to high medical costs?
Well,
Go ahead.
yeah, go ahead. Go ahead.
I don't think they like it. I think it becomes a barrier for them to do their job and to do their job effectively, because they're not the one setting the scales. They're not the one doing that. So I can't say that from a physician's perspective. I know a few physicians, and that's one of the frustrating parts of their jobs.
100%. So yeah, in terms of setting the cost, a lot of these discussions about billing codes and how much each diagnosis or each code that you put into the medical record, how much you're going to get reimbursed, is set primarily by proceduralists and by surgeons and not by general providers. So that is what hospitals get money on, right? It's the procedures that they do. It's not the preventative medicine that they do. It's not the general healthcare that they provide. And at a hospital like BMC, we will kind of discuss the costs of different tests and do a staged approach. So it does change our care because we don't want to run up this high cost. And it's interesting because I've had some conversations with like EEG technicians who are placing the EEG leads, and they're talking to me about billing codes. And they're like, well, if you leave the EEG on for another 12 hours, then we can bill for another day. And like, we don't care. Like, I'm like, we'll take them off when we don't need it anymore. And it just ends up being, from a medicine standpoint, a frustrating thing to think about that you just want to ignore. And you want to just do what the patient needs without having to think about the costs. But yeah, it's extremely frustrating.
The next question is for Dr. Wilson, and it's, do you personally feel like you have to conform to the pressures from the hospital? For example, the 15 to 20 minutes visits that Dr. Thomas discussed.
So I think as residents, you're relatively protected from some of that because you see less patients in your clinics. I'm lucky in that I went into a specialty where our new patients get 40-minute appointments. Sometimes they get an hour. And I intentionally went into neurology because we get to spend more time with our patients. And I knew that if I did primary care, I would be extremely frustrated trying to do everything that I felt I needed to do within 15 minutes. The providers that I do know that are in primary care and have those 15-minute appointments have extraordinary pressure to conform. Absolutely. And I do think that it compromises patient care 100%. And it definitely impacts the relationships that physicians have with their patients. Something that will happen is that, if you have to walk the line between, I only have X amount of time with this patient, but I want to build rapport with them and I want to make sure that I'm not missing anything and that I'm treating them appropriately. But if I run overtime, my next patient's going to be late and then they're going to be appropriately frustrated because I'm running behind. And sometimes you get double booked, and it's the time management is a big issue that I wish we also didn't have to conform to, especially primary care. I think they should have the most time with their patients because they're covering the most issues. Like, as a neurologist, I'm like, okay, I'm going to focus on your headache and that's all I need to worry about. But the primary care doctor is focusing on their asthma and their eczema and their poor growth. So I really feel for primary care doctors.
Next question is, have the panelists read the novel about Henrietta Lack? Sorry. What are their thoughts on this event?
So I have not read it. I've kind of heard the general topics of the book, but I'll let Dr. Thomas.
I haven't read it. I've seen the movie. And my thoughts are, I think everyone in my class knows my thoughts are, this is what has happened to Black people historically. It has a historical foundation on a lot of things. It's part of what historically science and medicine has done without thinking about other things, about taking her cells and using them and no consent and all of those things that happened. You know, we have institutional review boards now. We didn't used to have them back then. We did lots of things in medicine. Medicine did lots of things that they try not to do anymore. And it brings up a whole issue of how are Black and brown people treated in the healthcare system, and how are immigrants treated in the healthcare system. We can go the gamut, looking at different things that have happened to different people. It's about being vulnerable and marginalized, and how does the system do that? And also, how do we do research in those communities? Because we do need the research in those communities. We need to be part of the studies. We need to be part of the voices who design the studies. We need to be part of the policy making. We need to be the CEOs of the hospital. We need to be part of those conversations. One of the things that happens in education is that we teach it out of you. We teach you from a certain paradigm. And I say this to my classes, your job is to challenge everything. As students, that's your job. I want you to challenge me. I want you to challenge the test. I want you to ask questions, because if we just do just what it's in the textbook, or just go by this format, it's been a paradigm that's been very male, very white, and that's what we have to get away from. I remember being a graduate student, and we were in a health policy class, and I said to my professor, I was talking about the Tuskegee study and that it was racist, and he yelled at me. He said they were doing the best they could do, and I said, you didn't think that this study was racist? And he told me to leave his class. And we know the study was racist, so we know that, but it took time for us to really talk about it and things like that. So yeah, it's your job to challenge it. That's your job.
The next question was, how does one inform family members that don't agree to take the COVID vaccine?
I have one. I have two. I've taken a hard line. You can't come in my house unless you're vaccinated. It's not fun. I've taken that hard line because my sister got polio at the end of the polio epidemic, and she now has post-polio syndrome. So for my poor mom, being in the midst of this COVID crisis, this pandemic, brings her back to 1953, when she found my sister who took a nap because she wasn't feeling good and had a temperature, and she was paralyzed on one side. So it brings her back to 1953, and the fear is there. So I'm respectful of those relatives I have. I've talked to them blue in the face, but I have to protect my family, and my family has underlying conditions. Unless they get vaccinated, they can't come in our house, and that's unfortunate. It's hard and it's sad.
Yeah,
You have to be more diplomatic.
I think with any patient or family member, and when my family comes to me asking these questions, there are certain family members I know I can kind of be myself with and be their family member, and I know there are other family members that are coming to me as a physician, and I have to be acting as a physician in that role. But generally, because we come across this with a lot of parents who don't want to get vaccines for their kids in general. So a lot of those conversations start with, well, what have you heard? What knowledge do you have? Where are you getting your information? What concerns do you have? And I have zero expectation when I have that first conversation that I'm going to make any change. In fact, it almost never happens. But you say, you ask for permission, like, is it okay if I, just give you some information, give you my little spiel on vaccines and why I think this is good. And I sometimes will say, just so that I know that, you've heard it from me and I don't expect to change anything. And then they, most of the time, say fine. And then you see them again, a month or two later, and you say, hey, where do you stand on this? Where are we? Who have you talked to? What are their thoughts on this? And I've had a handful of patients who have then agreed to vaccinate their kid. Or you come to a compromise. It's not black and white, right? I think the COVID vaccine is more complicated because it's you either get it or you don't. But for childhood vaccines in general, it's okay, well, let's pick one. And I've had parents say like, okay, fine, I'll do one, but which one do you think is the most important? And that's hard. But, you take baby steps and you go along the journey with them and try to support them and give them the best information to make the choice for their health. But again, you can't force anybody to do anything. So it's tricky.
And I can say I have the one family member who changed their mind after asking me over and over and over, why do you think this is important? And I said, your cousin had polio. What more example do you need? And they did get the vaccine. They're getting their second shot in a couple of weeks. So I thanked her and I said, we have a big family party during the holidays. And, we haven't had it. We're not going to have it this year. I don't know if we're going to have it next year. But she sat and she thought about it. She listened to me. She listened to other people. I wasn't the only person that talked to her. But I think having someone close to you that you see what's going on. Also knowing people that have passed away from COVID. I know 11 people. And I'm sure you must seen many, many at the hospital. And that, that hurts your heart. And so my one cousin changed her mind, got the vaccine. I think it's important to get the vaccine because COVID's very different.
So feeding off of that question, how do you tell them that the vaccine is safe when it seems like it's been processed in such a short period of time?
Listen to the scientist. I think from the past, we have all this mistrust of the government, the scientists. But when you hear that Bush was working on it, Obama was working on it, when you hear the history where the vaccine came from, and when you see the other part that, how many people do we have to have pass away? Over 500,000. And then when you see people who've gotten the vaccine and they're doing okay, I think it's hard, but it's not really fast. Dr. Wilson, you know more about that science than I do. They've been working on this for a long time. We knew something was coming. That's the shock to me. We knew it. Why weren't we doing it even more?
Yeah. I think the number, especially now, but the number of patients that they tested it on wasn't that small. And, the side effects that you see really aren't completely different from just general vaccines that you see. You can make it depends on what the person's going to respond to, but you can make it individual and say, I did it for myself. If you're a parent, you can say like, I gave it to my adolescent child, and if I would not ever ask you to do something that I don't feel is safe enough for me or for my mother or my sister, or somebody that I'm caring for. And I think a lot of patients kind of respond to that in terms of like a human relationship, and you kind of take yourself out of the provider role and just become a human. But yeah, I think especially now enough people have gotten it that we actually have really good data. And part of why it was rolled out so fast is because they had funding, right? So some of these studies take a long time to do because they don't have the funding to roll it out on thousands of people right away. So, they had the backing to get this done quickly, which was the right thing to do. But so I think that's a big plus, and just putting into perspective a little bit.
So I believe this one is the last question. If anyone else has any more. So as a physician, how do you face the complications mainly from personally or as a team patients can bring to doctor appointments when they say they cannot afford or pay for the visit or their medicine?
So that's part of the reason I work at BMC. I love BMC because I rarely have to think about insurance, and my patients rarely have to worry about paying for a clinic visit, like almost never. BMC often eats the costs of tests. So there are some genetic tests that if our patient's insurance won't cover it, BMC just loses that money. And the hospital has agreed that that's okay with them, which is wonderful. I think another great resource is almost every hospital, I think every hospital has a like financial aid department for patients. So you refer them there, and there are ways that patients can fight any bill that they get. And oftentimes the bill gets cut to like a fraction of the cost if the patient just says, I can't pay for it. So that's nice. And with medications, again, a lot of it is fighting with the insurance companies, getting prior auths, doing peer-to-peers, and working with the patient to get it approved. There are medications that you know are going to be more expensive, so you do that process beforehand to avoid the patient from having to pay for it. And I've told patients, like, if you go to the pharmacy and they're telling you that you have to pay for it, tell them to call me and we'll work it out, or tell them that they have to talk to your insurance company and we'll work it out. So luckily, I think it hasn't been as big of an issue working at BMC. I'm sure at kind of more specialized hospitals, it might be more of an issue, but they also have more financial support to kind of eat the costs of patients that don't have insurance. And I think hospitals as a whole try to do as much as they can to avoid giving patients like huge hospital bills. At least in, I think, pediatrics, people are also nicer. So we're lucky.
There's actually one more question for you guys. So what are your thoughts on what's happening in India with COVID at the moment?
It's tough. It's really tough. I think they're kind of seeing the perfect storm and are having big issues with like getting the resources to tackle the surge that they're seeing and treat those patients. And from a public health standpoint, like social distancing, and I think is really hard for a lot of families. It's devastating.
I'm glad there's been a global response for people to come and help. I'm glad the US is being part of helping that. But I think it's, again, more evidence of how different COVID is, how the pandemic is global. This is not a US problem. This is not a Europe problem. This is a worldwide problem. This is a different type of war. And we have to treat it like that. And I think when President Biden became in office and he took that stance to treat it and devote policy, devote money towards that, I was appreciative of that. Me as just being in my little world, it gave me some relief. And I feel for the people there. Unnecessarily, people are going to lose their lives. And I'm glad that we are part of responding in kind, and that we're rebuilding our foreign relationships. I think that's really important, and other people are responding to them as well. And that's what we should do. It's a humanitarian effort.
Mm-hmm.
Okay. Well, if there isn't any if there isn't any more questions, I'm going to bring the meeting to an end. I just want to say thank you so much for Dr. Wilson and Dr. Thomas for coming in and sharing your perspectives on health inequality disparities within the healthcare system. We were greatly appreciated for having you guys coming in and everything.
Well, thank you for asking me. It's been an honor to be asked.
Thank you guys so much. Good luck with all of your careers. And if y'all have any questions, please feel free to, reach out. I'm happy to chat.